Thank you for watching this exclusive preview of the CME-accredited activity, Current Standards and New Directions in the Treatment of Acquired Thrombotic Thrombocytopenic Purpura, presented by Dr. Sparrow Cataland, Professor of Internal Medicine at The Ohio State University. To bring this meeting to your institution and hear more about how new treatments are transforming patients' lives, please scan the QR code and request a meeting today.
We start to get some better data on exacerbation when we look at the use of caplacizumab. We mentioned this several times already, so we should talk more specifically about what it is. It's a small molecule, an antibody that's derived from heavy chain antibodies alone that are typically seen in animals of the camel family. You see some camels here. This was originally derived from a llama, though. It's given subcutaneously. It's given concurrently with plasma exchange. It's not appreciably cleared by plasma exchange. But it's most important to mention what it does. It blocks microthrombotic disease. It binds to the A1 domain of von Willebrand factor. So where these ultra-large multimers want to spontaneously bind platelets, they're not able to do it. So it blocks microthrombotic disease, but it does not improve the ADAMTS13 deficiency that led to these ultra-large multimers being present. So important that you build temporizing measure, not too dissimilar from plasma exchange therapy. We look at the very first study, the phase 2 study, which was called the Titan study. The eligibility criteria were patients with a clinical diagnosis of TTP. So the platelet count was less than 100,000. They were felt to be having an acute episode. They had no active bleeding. Because as we'll talk about soon, if this molecule inhibits von Willebrand factor function, you can induce a mild bleeding type of patients. The other eligibility criteria are people who required plasma exchange therapy for this diagnosis of TTP. The primary endpoint was the time to a response or a normal platelet count, which again is that marker of the absence or stopping of new microthrombotic disease. But some key secondary endpoints that we'll talk about, especially exacerbation and relapse, which should not be affected by caplacizumab, as well as safety. So this was a single-blinded study, one-to-one randomization to get plasma exchange, steroids, and with caplacizumab or placebo. What's important to remember here, there was an IV loading dose. They got daily subcutaneous caplacizumab, but they also got caplacizumab for 30 days after the last plasma exchange procedure. So this is covering that exacerbation time period. So can this drug block the early recurrence of this disease? And what you might expect, and you should expect in the caplacizumab-treated patients versus the placebo patients, if you're blocking the formation of microthrombotic disease, the platelet count should get better quicker. And that's indeed what we saw.